Based on the extension of the regular full endoscopic interlaminar technique, which we now regularly deploy for treating most of the disc herniations, but there is a select subgroup of patients that we come across which are severely migrated herniations, and in treating those herniations we always wonder what is the best approach. Do we need to excise more ligamentum flavum, or we have to do a more of bigger laminotomy or laminectomy sometimes? So by definition, the high migrated herniation, this particular approach is specifically meant for high migrated herniations. That means that the herniations which are in zone 1 or zone 4. So Lee et al. Had classified this high migration in 2007 and published it in European Spine Journal, where the boundaries are defined by the watershed lines for upward and down migrated herniations are line A and B, which are basically the lower border of the upper pedicle of that segment and lower border of the lower pedicle. So these are the two lines. So any herniation which is crossing the mid of the lower pedicle to the lower border and beyond is grade 4, and similarly which is crossing the distance between the lower border of the upper pedicle and the vertebral end plate of that vertebra, the middle of that is the zone 1. So these are the primary herniations which will be the matter of concern to this particular approach. So when we have to treat these patients, all the available surgical options are already challenging. So if you have to do a microscopic surgery, you require extensive bone and ligamentum flavum removal on that side. Sometimes it can actually lead to a hemilaminectomy on that side. So like this. Similarly, if you deploy a transforaminal approach, it can be difficult to perform, and you have to tilt the scope and keep the cannula specifically in the epidural space like a floating cannula technique, or sometimes you have to do a foraminoplasty by drilling the superior tip of the superior articular process and then tilt the cannula in that following the herniation. And there is still a chance that you will end up with a residual disc herniation. Similarly, full endoscopic interlaminar approach or biportal, they have the similar demerits just like a microscopy, because you have to keep drilling the lamina to follow the fragment which is gone up to the upper pedicle or sometimes beyond the lower pedicle. Now, this particular thing comes handy, the translaminar approach. So the idea of any minimally invasive or least invasive technique is that you should be able to access the pathology while causing least collateral damage to any of the other structures around. So if you have to remove lamina or the whole of the ligamentum flavum, then the whole beauty of the full endoscopic technique gets compromised, and that is where translaminar comes into picture. So what does translaminar approach mean here? You drill a hole in the concerned lamina. So if it's a up migrated herniation, you drill a hole in the upper lamina. If it is a down migrated herniation, you drill a hole in the lower lamina, right onto the fragment where the fragment is lying. So you access the herniated fragment directly, you decompress the neural tissue, and there is no collateral tissue damage because you are not cutting the ligamentum flavum at all. Sorry. So this is how this is done, that you dock the cannula onto the lamina and then post-operative CT showing how the hole has been drilled in the lamina. Majority of the hernia mass is migrated away from the, this is indicated where majority of hernia mass is migrated away and is primarily sequestered. It should not be connected to the parent disc. If it is, then you may have to go to the level of the disc to do an intradiscal decompression, and this approach may not be handy. So you have to keep it focused only to certain select group of patients which are large migrated herniations disconnected from the parent disc. So there are already some published papers on this. Some people are utilizing stenoscope in the beginning and then changing the scope in between, but I personally do only with the one single scope, which is the interlaminar scope, using the 4.1 mm working channel with the 8 mm working cannula. The working cannula is directly docked over the lamina beneath which the herniated fragment lies, like this. We will just show you a small video. So you expose the laminar bone of that particular level, clear it of all the soft tissue and the muscle, and then you visualize the spinolaminar junction. At the same time, you also check the lateral edge of the, by seeing the lateral edge of the pars. Now this defines your working window, so you have to not cross the lateral edge of the pars, otherwise you'll break the pars. So you drill a 6 to 8 millimeter hole most of the time. Sometimes you can extend it depending upon the herniation, but keep the cannula docked onto the lamina. I don't recommend advancing the cannula inside because you do not know how much the herniation has changed the anatomy. So instead of pushing the neural element on this side or that side, just keep the cannula docked. You can advance the scope in between to have a closer look. So scope, you can go close to the epidural space, around the nerve tissue, around the thecal sac. So I'll demonstrate this with a couple of cases. This was a 47 years male, left leg radiculopathy with thigh and knee pain, and his MRI showed a large sequestered L3-4 herniation, which is right going up to the pedicle of L3, you can see here. So fragment is lying besides L3 pedicle. So we identify the lamina and then dock it right in the middle of the lamina. This is a small video. So once the cannula is positioned, we clear the lamina from the soft tissues and we start drilling with a cutting burr in the beginning, and then we can switch over to a diamond burr. Now once the posterior cortex is breached, we use the Carrison, and now we see the lateral edge of the thecal sac, and just lateral to that. What happened? Yes, please. They're still setting up.
So what is your technique? So do you fear that if you drill too much, then you can break the pars also there?
Yeah, so that is why I was saying that you define your medial and lateral edge. Yeah, okay. So then in that case, you will not be, you will intentionally avoid drilling the lateral edge of the.
Can you set the clock for 4 minutes, please? Timer, 4 minutes.
So I'll answer that question once we finish. Yeah. So as I said, just a revision. So we are opening, this is the lateral edge of the thecal sac, and we are in the axilla of the exiting nerve root. So first you identify the fragment which was besides the pedicle and pushing the nerve root laterally towards the pedicle. And as you remove the fragment, and now you can see this is the exiting nerve root very nicely decompressed. So this is a very targeted kind of a surgery. You do not need to go fiddle for the other fragments anywhere, because you have already defined that this is your main culprit. This is the post-op MRI and CT scan showing nice decompression through the translaminar window. Another similar case, in this case this was a multi-fragmented herniation, and many times these sequestered herniations are multi-fragmented, so one needs to not get satisfied only with one fragment until it is already decided from pre-op MRI. And as you open the posterior cortex, you just feel the thecal sac, and then you coagulate the epidural vessels and then start widening the window with this tube sheath punch. So the last widening I usually prefer doing with the punch. And once the adequate, this is the lateral edge of the thecal sac, again we are in the axilla of the exiting nerve root. So that will be coming into picture once we do the decompression. So one large fragment comes up. Now see we can go very close to the neural elements with the endoscope, and we can, this is the exiting nerve root, and you see the vertebral body surface here, which shows that complete decompression has been done, and all through that small window. So this is the post-op MRI of the same patient. So this is down migrated. Primarily we come across, usually these high migrations happen superiorly, but occasionally you do get down migrated herniations, like in this case you see there is a large down migrated herniation at L3-4 again, and the fragment is again lying under the beneath the L4 pedicle in this case. So this was the post-op MRI. So we have done about 10 cases nowadays with this approach, and these are the patient parameters. Most of them are elderly, 50 plus. Sometimes you do come across these patients in the younger population, and most, as I said, were either in zone 1 or 4, and 8 were up migrated and 2 were down migrated. The preoperative VAS score and the ODI showed significant change after this, because again it is a targeted removal, and the neurological deficit also showed reasonably early recovery after this surgery. So to conclude, this is surgery meant for a very specific set of patients which are otherwise not easy to manage by the conventional techniques. So it is very useful and handy to do a targeted fragmentectomy focused only on the fragment, least invasive for this particular segment of population, and you do not have to cut the lamina and the ligamentum flavum extensively. But yes, there is a limitation, as I already mentioned. It is not meant for patients who are having a associated herniation at the level of the parent disc. In those cases, you may have to resort to a conventional interlaminar approach. Thank you.